I'm Dr. Raghu Satyanarayan, practicing consulting physician at Ahmedabad for the past 32 years. I'm here to present a case of diabetes with hypertension and microalbuminuria. Here is a 57-year-old type 2 diabetic for 4 years. Patient visited the clinic with weakness for the past 2 months. During routine checkup, she complained of generalized weakness. Hospitalized for acute coronary syndrome 1 year ago. She's on metformin 1 gram BID, glimepiride 4 milligrams once daily. She's also on losartan 50 milligrams once daily, atorvastatin 40 milligrams once daily, amlodipine 5 milligrams once daily. She's also on chlorthalidone 12.5 milligrams once daily. And she's also taking metoprolol XR 50 milligrams daily, along with aspirin 75 milligrams once daily. Because she had been hospitalized for acute coronary syndrome once daily, so she's on a statin, she's on antihypertensive drugs, she's also on metoprolol, a beta blocker, to protect her heart. Her lab parameters were A1C of 8.2, which is above control. Her eGFR is 88 ml per minute. LDL-C is 75 milligram per deciliter. HDL is 37 milligram per deciliter. Triglycerides are 156 milligram per deciliter. And the total cholesterol is 168 milligram per deciliter. Her AST, that is the SGPT, is 33 units per liter. Serum creatinine is 1.1 milligram per deciliter. She also has an UACR, urinary albumin creatinine ratio, of 150 milligrams per gram. Her physical examination revealed her BMI is 31 kilogram per meter square. Her blood pressure is 120 by 70 meters of mercury. And heart rate is 78 beats per minute. Her BMI is 35. Here is an overweight lady. Indians should have a BMI of 23 or 24. But her BMI is 31. She is an overweight diabetic patient. Our first goal is to optimize her glycemic control with cardio-renal protection because she is also having proteinuria. UACR is 150 milligram per gram, which should be less than 20 to 30. And here her urinary albumin creatinine ratio is 150 milligrams per gram. So we are here to give her a comprehensive treatment, which will give her cardio-renal protection are the primary treatment consideration. A1C goal for many non-pregnant adults of less than 7 is appropriate. On the basis of provided judgment and patient preference, achievement of lower A1C, such as less than 6.5, may be acceptable if this can be achieved safely without any significant hypoglycemia or other adverse effects of treatment. A better management during the last 2 decades allowed the reducing the incidence of cardiovascular complications, yet the residual risk remains high in patients with type 2 diabetes. CKD remains a concern, at least partly due to the reduction in premature death among type 2 diabetes patients. Renal disorders are common in type 2 diabetes, with approximately 50% of patients developing some degree of renal impairment and an increasing prevalence of both conditions over time, that is cardiovascular disease and diabetic kidney disease. The risk of renal disorders in type 2 diabetes includes the development of multiple phenotypes of organ damage, often overlapping, and ultimately progressing similar to what occurs for cardiovascular disease. EMPA-REG outcome was a randomized, double-blind, placebo-controlled phase 3 trial involving 7,000 people with type 2 diabetes, almost all with established cardiovascular disease. The mean eGFR at baseline was 74 milliliters per minute, and the median UACR was 18. Pre-specified renal outcomes in the study included incident or worsening nephropathy. And what is worsening nephropathy? Defined as progression to macroalbuminuria, from micro to macroalbuminuria, doubling of serum creatinine associated with an eGFR a main driver for the reduction of nephropathy with empagliflozin was a slower progression to macroalbuminuria. The hazard ratio was 0.62, that is 38% risk reduction. Compared with placebo, empagliflozin was associated with significant improvements in post-ad hoc composite endpoint of incident or worsening nephropathy or CV death. That CV death was reduced by almost close to 39%. Progression to macroalbuminuria was reduced by 38%. And initiation of renal replacement therapy was reduced by 55%, with no differences reported between the two therapeutic doses, that is 10 milligrams or 25 milligrams of empagliflozin. The inhibition of SGLT2 leads to tubuloglomerular feedback via enhanced natriuresis and delivery of sodium to the macula densa, thereby decreasing diabetic glomerular hyperfiltration due to hyperglycemia. This is hypothesized to reduce the resulting chronic kidney damage. Ketone bodies are a more energy efficient fuel in the renal tubular cells than glucose, and as a result, renal oxygen consumption is reduced in the presence of mild ketosis. Hence, it has been suggested that the use of ketone bodies as energy substrate in patients receiving SGLT2 inhibitors may contribute to the renoprotective effects of these agents with a similar mechanism as in the myocardium. So all the myocardial benefits are also because of ketones. DPP4 inhibitors reportedly ameliorated the renal functions and the pathology in diabetic kidney disease. Linagliptin decreased the podocyte apoptosis, one feature of diabetic kidney disease pathology, by enhancing insulin signaling. Carmelina study, which is a linagliptin CV outcome study, confirmed that linagliptin reduced the progression of albuminuria by 14%, reduced risk of progression of albuminuria. Moreover, linagliptin demonstrated CV safety, including in patients with advanced CKD. Linagliptin slowed the progression of albuminuria without affecting the eGFR slope or other kidney outcomes. There is a strong rationale for combining DPP4 inhibitors and CV protective class of SGLT2 inhibitors in patients with type 2 diabetes, because two drugs exert different and complementary glucose lowering effects. In fact, among these SGLT2 inhibitors, it's only empagliflozin which has established cardiovascular protective effects. Furthermore, the increase of glucagon levels induced by SGLT2 inhibitors may be blunted by co-administration of DPP4 inhibitors. Instead, DPP4 inhibitors not only act on the alpha cell, not only acts on the beta cells, but it also acts on the alpha cells, reducing the release of glucagon. Clinical evidence shows that SGLT2 inhibitors and DPP4 combination is an effective option for management of type 2 diabetes, providing A1C reductions of 1.1% to 1.5% and weight reductions of approximately 2 kilos when added to metformin, which is its primary place in therapy. Instead, this is a wonderful combination in terms of efficacy and without any risk of hypoglycemia. In phase 3 randomized trial investigating efficacy and safety of empagliflozin and linagliptin, better tolerability was observed in the subject who are on empalina 25/5 than those on alone empagliflozin 25 milligrams in terms of serious adverse events, that is 4.4% versus 7.1%, and hypoglycemia 3.6 versus 3.5, genital infections 2.2 versus 8.5. That is, if those patients who are on a combination fare better in terms of genital infections also. This fact implies that empalina added on to metformin constitute an equal or even better tolerability than monotherapy with additive glycemic efficacy in uncontrolled patients. This unique combination lends itself readily to early treatment intensification because of good glycemic control and tolerability and possible weight loss also. This lady had a BMI of 31. So we need to give medicines which will help weight loss also. Cardiovascular protection and minimal treatment burden. Pill burden is reduced by combining these two agents in one tablet only, and offers renal protection also in this lady because she has a UACR of 150 in patients with type 2 diabetes at high CV risk. Thank you.